on that count today. So really appreciate everyone turning out and really appreciate your partnership in stroke care. It's an evolving process. I chose some information which I thought you might find useful. And also would love to have the opportunity to come back every 6 to 12 months and focus on topics that you all want to hear about as ED providers taking care of stroke patients. And left a little time at the end just to discuss logistical issues. I think those always come up, and hopefully with your team and our team communicating, we deal with them in a fairly efficient manner. So what I'm going to talk about today, we've done our introductions. I'm going to go over some of your data from each of your sites and also as a composite. That's where we learn about how to do quality improvement, review the treatment time windows, discuss the low or mild stroke, low NIH stroke scale scores, discuss stroke mimics. I did throw out an email to your group about any cases, and we could always do case reviews as appropriate. I didn't get replies on that, but I did hear back from some of you, so thanks for that. And then Q&A at the end. And again, this is only useful as a way of helping you take care of stroke patients, so also feel free to modify, make recommendations to modify the format and the presentation. So the data review, you guys can all see the slide that says stroke volumes. Very good. Thank you for nodding, Scott. And so what you see here, and can you see my cursor moving across the screen, the arrow? Great. So here you can see Prob Milwaukee. This is 2019. This is 2020. You can see Providence, Portland, and St. Vincent as references, and then each of the individual Samaritan sites that we collaborate with around telestroke, what your volumes are. 2020 is up through the October, some point in October for these numbers. That's why they're smaller. And for the different stroke subtypes, you can see blue is intracerebral hemorrhage ischemic, which is always the majority of cases. Ones where we didn't have a diagnosis or unspecified subarachnoids, and then TIAs. And you can see TIAs and ischemic are first and second, not in that order, and then hemorrhages third. So you guys have significant volumes at all your sites. Certainly, as good, if not higher than most of our telestroke partner sites. The treatment rates. So this is taking patients who present in a time window where they could be considered for a thrombolytic, what is the ischemic stroke treatment rate. And if you look at data from 5 or 10 years ago nationally, that number was somewhere between 2 and 5% with IV Alteplase. And you can see that the Samaritan hospitals do very well. So our hubs, 12 to 13%, we hover around, slightly higher in 2020. And you can see that your partner sites, or the Samaritan sites, I should say, have very high treatment rates. And that corresponds with patients presenting in a time window who qualify for treatment, who are treated. And the patients who present in that time window who don't qualify are part of the denominator. So it's pretty hard to get, you can't really get to 100%. And the way to look at this number is how do we compare to other healthcare systems and our individual hospitals? And I would say you guys are doing great. Any questions about that? And this is just another way of looking at the treatments, but in terms of door to needle. So the American Stroke Association has a program called Target Stroke, which is about getting patients treated faster, and they keep moving the goalposts. Door to needle, 50% under 60 minutes used to be the number. Then they bumped that up to 75% with 50% under 45 minutes, and now they're saying they want 50% under 30 minutes. So a lot of hospitals that were Target Stroke, bronze, silver, gold, elite plus, which are the awards that they hand out, are not going to be elite plus this coming year because of that 50% under 30 minutes. So if you look at our hub sites, we do the St. V's and Prob Portland, which are higher end stroke centers, do pretty well. in the median time of door to needle being 40 and 43 minutes and then dropping into the 30s. What's really nice to see is if you look at 2019 in the Samaritan hospitals, you can see that less than 75% of patients were treated under 60 minutes at all the sites. And in 2013, a lot of those have gone to at least 75%. And you can see that in every case, with one exception, it looks like there's no change for the big hospital. When I talk to the smaller sites, they always call it the mothership. No delta there, but everybody else is doing better, and that's great. Any questions about that door to needle? Really nice performance. And then we'll talk a little bit about what feeds into that. So unfortunately, and I'm going to go through each site's data. This is the emergency department stroke timelines. Door to first seen by ED provider, excellent at Albany. Door to stroke team arrival, I queried our data person. We don't have an entry for that. And I actually think what should be part of these is door to when the stroke physician was paged. Because that correlates, as I'll show in a subsequent slide, very, very closely with more than any other variable with door to needle. Door to CT, you want that under 25 minutes, and I think every one of the sites does great on that. So you're seeing the patients quickly here. We don't have the stroke team notification data or the arrival, which corresponds to that. Door to CT is good, and door to needle is looking really good. 39 is the median. The N is not huge, but that's a really nice performance from Albany. And then the hospital in Corvallis, the regional medical center, we saw door to needle 52. We can see door to CT and door to the ED docs are seeing these patients really fast. That's great. You'd really like to know why that number's higher at the largest center, and we can do some breakdown on that if I spend a little more time with our data analysts. But there's room for improvement there. And the other thing that you'd ask when looking at these timelines is, okay, when was the stroke doc called and when did they arrive? You know, if you call them early and they beam in late, it doesn't help the door to needle time. So just keep that in mind. Looking at Lebanon, again, smaller numbers than the main center in Corvallis, but door to needle 51 minutes. Door to CT and door to doc are great. So nothing to criticize there. Likewise, North Lincoln, door to needle median is 43, really great. Very close to our hub performance. 1 minute is the median time for the doc seeing the patient, and 16 minutes to CT. That's great. Similarly, the Pacific Community, door to needle, median 53. In 2020, seen within a minute. The CT is done within 5 minutes. I mean, that's really impressive. This is what I was referencing earlier, the correlation of the telestroke page to door to needle. This was just looking at several cases. And so the dark line is the door to the telestroke page, and then you can see when it's longer, the door to needle time goes up significantly. So what I would encourage, and as a telestroke provider, I know this firsthand, ED docs are really respectful to the stroke providers. I mean, we feel very appreciated, and often they don't want to bother us unless they think it's a real stroke. They always act apologetic when they don't know everything about the patient. And sometimes they don't want to call us until the CT is done. You should never hear stroke docs say, call me back when the CT is done. They might say in a patient who's 12 hours out, I'll call you back when the CTA is done, because thrombolytics are off the table and they're talking about interventions. But you should never hear call me back when the CT is done when a patient's in a thrombolytic time window. Any questions about that as we go along or in reference to the specific data? Obviously, having this door to stroke team arrival would give us clearer insight into why door to needles are longer.
I just think that the door to stroke team arrival time should be the time that whoever the telestroke doctor is that they log on to the machine, onto the robot. That would probably be the clearest, arrival of the stroke team in our case.
And we do have that data in that when the telestroke provider completes their note, we have a teleportal where we have to document the different time elements, and we document our beam in time. But you're completely correct. It's very difficult for us to say, why is your door to needle time high when we're not showing you the data about when the beam in time was. What I will say, though, I can be confident a component of it is the docs are seeing the patients early. When you think it's a stroke, activate the stroke pager before the CT is done, before you have more data. It gives us lead time.
That's what we've tried to do, and we've tried to automate it so that as soon as the stroke is called and the patient is on their way to the CT, that page is sent out immediately so that we expedite that as much as possible.
Great.
And then our current metrics for activation to beam in is less than 15 minutes is our current telestroke goal. Just FYI.
Yeah, and personally, I love to beam in and see an empty room because I know I got there early. The patient's still in the CT scanner and coming back. The other thing I would throw out there in the thrombolytic time window, and this is a delay that we have at our hubs and we don't know how to capture it very well, is getting the CTA. And my general recommendation is that if it's going to be more than 5 to 10 minutes to get the CTA because of IV access, skip it. You can get it later. And the thrombolytic time window shouldn't be extended. And then there are natural things that extend the time window, consent discussions that are complicated in low NIH stroke scales, or the family member who says, I want you to call my uncle to discuss this, or controlling blood pressure and so forth. Any other comments on the door to needle before we move on?
This is Scott Grupus. I would say that getting the CT and the CTA separated out for the radiologist, I don't know that we have data on this yet, but it seems to have made a big difference on getting those initial CTs read and results back and getting them transmitted everywhere. I don't know if you guys are seeing that, but it seems to, from my end, be a smoother process and hopefully getting data to you guys quicker.
Great. So one question we always get is about the complications of our treatment. We always talk about using the NIHSS data that there's a 5 to 6% risk of intracerebral hemorrhage and with neurologic worsening, and a 1% risk of intracerebral hemorrhage and death. These are the treatment complications from across our system. I don't have them broken down by sites, and I think the ends are pretty small. You'd have to look at something like this where you're looking at several years of data. So here you can see the complications, and complications are considered intracerebral hemorrhage, any type of hemorrhage, and death. So it's going to be a higher number than just intracerebral hemorrhage. And you can see for intravenous only, intraarterial only, and what that means is thrombectomy, and then the combo, that we have roughly a 3 to 4% all complication rate. Overall, if you crunch all these numbers from across our system, our telestroke system, it's a reassuring 3.6% complication rate. Any questions about that? All right. So this is something we come across a lot. Thrombolytic treatment for low NIH stroke scale scores. What degree of disability merits thrombolytic? I know there are members of the ED community that don't feel like thrombolytics are ever fully merited, but that's a separate conversation, which I'm happy to have with you at another time. So, you get these people with mild strokes, and it used to be a lot of conversations, NIHSS 3, NIHSS 2, should we treat this patient? And what we know is that 30% from the Get With the Guidelines larger literature, milder improving stroke, who are not treated, die or are not discharged home. So we know that there's a significant disability even in those lower NIH stroke scales, or what are reasons for not treating mild and improving. Complications for low NIH is actually even lower from larger data sets, 1.8% for intracerebral hemorrhage with worsening and 1.3% for mortality. And what I do is ask myself this question to make it as simple as possible. If this person was unimproved, would they be able to live their life the way they did before? So leg weakness in a paraplegic is not going to be, or paraparetic is not likely to be disabling. On the other hand, someone who has a field cut, and that's all they have, a PCA stroke with a field cut, that's a 2. They're not going to be able to drive. And one of the tools that we use to sort of augment the NIH stroke scale scores, we call G3. We haven't thought of a sexier name yet, but gait. Can the person walk? I've seen patients with an NIH of 0 who couldn't walk from gait ataxia. Grip. Are they able to hold an item and move it purposefully with their hand? And gag. Can they swallow? And you'll have someone with mild dysarthria maybe, but you give them water and they can't swallow. And one of the phenomena that I've noticed is swallowing gets harder as you get older. People in their 70s and 80s are, choking much more often than they did 20 years ago. And then you give them a little dysarthria, and very often it's the line between swallowing and not. So again, simplifying it, any disabling deficit at the time of assessment merits treatment, assuming that the patient is otherwise qualified. Any thoughts about that from the ED group here? And very pleased to have so many ED providers in the audience. It's really rewarding as a speaker. All right, does that make sense? Thanks. All right, the slide's kind of screwed up, so I'll just go through that. So I was talking to some of our ED docs who are as long in the tooth as I am a couple weeks ago, and it was clear to me that they didn't understand the time windows. They just basically called the stroke team, and they, as I was telling them what the windows were in brief summary, as I will do now, they were actually writing it down. So I thought perhaps this would be useful. So IV thrombolytic, 0 to 3 hours. That was from the New England Journal article in 1995 and FDA approved in the United States in 1996. IV thrombolytic in the 3 to 4.5 hour time window. This was from the ECAS-3 study published in Europe. The stroke severity was a little lower. When we talk about the IV thrombolytic benefit, in the 3 hour time window, we talk about a 17% absolute benefit. So the chances that you'll be disabled at 3 months go from 33% without treatment to 50%. And that's with a 5% risk that we talked about before of worsening and 1% of death. So a pretty narrow therapeutic window, which gets even narrower in the 3 to 4.5 hour time window. So it had an absolute benefit of 7% with a 4% ICH risk. And that's why a lot of people are not enthusiastic about the 3 to 4.5 hour time window, which is not FDA approved in the United States, but the stroke and heart associations make a recommendation that it should be considered. The other place where it really gets even more complicated is that in the ECAS-3 study, they excluded patients over the age of 80, and they excluded patients who had diabetes and a previous history of stroke. So do you not include those patients? And what the Stroke Association says is to consider treatment. Personally, not a big fan of the extended time window, but we offer it, and I give people the numbers, and that's a tough thing to do to a stroke patient or their family is, what's 7% versus 5% and what's a 90-day outcome. I mean, it's a challenging scenario to have truly informed consent. Endovascular thrombectomy, the 0 to 6 hour time window, the devices were approved in 2004. They actually showed efficacy finally with these stent retrievers. So they had a lot of devices for pulling out clot, but it wasn't until the device was actually an expandable stent that went into the clot and was left there for 5 minutes that we started seeing efficacy. And the reflex after 2014 and even before it, when the devices were improved, was that if it was under 6 hours, you take a patient to the cath lab. What really dramatically changed the clinical scenario that we practice in was the 6 to 24-hour window, where multiple studies showed that if you have patients with large vessel occlusions, and the only ones they included were middle cerebral artery M1 or distal internal carotid occlusions, some M2s, which is where the bifurcation of the middle cerebral artery takes place, they showed the number needed to treat to get one good outcome was 2, and that 50% of the patients benefited. But you have to do a perfusion study. And I don't think, if I'm up to date, that any of the Samaritan hospitals have them. And we don't recommend that you necessarily have one, do perfusion studies, CT perfusion, unless you have an endovascular team on site. Because the time of transfer, it's a different brain by the time they get there. We do the CT perfusion studies typically at the hub sites. So hopefully that's useful to you. Any questions about those treatment windows or the treatments themselves? All right. So stroke mimics, I know this is sort of the bane of ED docs, and I actually got a phone call from one of the hospitalists at Albany who said the last 5 TPA patients I had were all stroke mimics. What's the deal? It's a waste of resource, and it's also not clear because sometimes they're saying it's a resolved stroke. I think these are all mimics. Can you talk to me about that? So what I shared with him is that if you look nationally, 10 to 30% of US, depending on which literature reference you're looking at, 10 to 30% of IV thrombolytics are treating mimics. The most common are seizures, post-ictal states, migraines, conversion disorders. I would put vestibular complaints, vertigo in there as well. If you're treating a patient who hasn't had a stroke, there's a very low complication rate because the ischemic brain is not going to bleed because they don't have it. And if you can do MRIs acutely, you can lower the mimic treatment rate down to about 2 to 5%. But most facilities, including our own, can't very quickly do MRIs on every stroke patient. Some we can, but in general, and I've noticed in some Samaritan hospitals, they're actually really good at getting MRIs up front, much better than we are. But it's sort of the lay of the land and sort of the accepted cost of doing business, which IV thrombolytic is an expensive drug. So Natalie Swearingen, who's the nurse coordinator at Prov Portland, did this survey of the IV thrombolytic treated patients in 2017 and 18 at Providence Portland Medical Center. And what you can see, kind of consistent with the previous slide, is the mimic rate. In 2017, the treatment rate was 17 and 26% in 2018. And what the underlying discharge diagnosis as verified by a stroke neurologist was. So again, I think it's just sort of it's the imprecise nature of what we do in the absence of MRI, but we're exposing our patients to very low complication rates. But not trivial, right? 1 out of 11, 1 out of 14. Any questions about that? I'm not sure how to refine this. I don't think stroke docs are that much better at weeding out mimics. So where are we now? And this is just describing the service. It's an evolving dynamic. Telestroke was born as an acute stroke treatment tool for getting phone calls from you guys for any patient who presents with disabling deficits in under 24 hours. Hopefully we're doing a good job in caring for those patients. But we do take calls from ED docs and hospitalists on complex stroke management. Our goal is to keep your patients in your community. So if we can help take care of them, I know not having in-house neurology limits that ability, but we are a resource. And routine care questions. Should I put this patient on aspirin and Plavix? Should I get an MRI or a CAT scan on this patient? I think it's a little hard because the providers who are currently doing the non-acute conversations are also handling acute pagers. And sometimes you have to wait 10, 15, 20, 30 minutes, sometimes even longer to get a call back for a routine question. What I try to do is call back and say, I'm dealing with an acute stroke. Please let them know it's going to take a little while. You may also get some pushback from providers who are saying, you're asking me to do a consult. This is really too complicated. I don't feel comfortable without examining the patient and having access to their chart in giving you a fuller opinion. Hopefully that's a friendly, comfortable, mutually agreed upon dialogue about where to draw the line. We are discussing at the system level with Providence and Swedish having a non-acute consult service, but we need more providers to be able to do that. I think the other challenging dynamic, which we hear about sometimes, is, why don't you order the IV TPA on the patients if you're doing the consult and the consent? Can't you order it? And with Samaritan, there are a number of reasons why that doesn't happen at the system level. It takes a lot more time, believe it or not, and also we need access to the chart. And Samaritan, our providers don't have access. Any feedback from your side after I've described how well we get along in an ideal world, where you see issues or problems? And this is, please be candid.
This is Raj Bayman. Sometimes when I'm talking to the stroke provider, it's unclear whether they're local, meaning Portland-based, or if they're somewhere far afield. And of course, I'm assuming they're from Portland. I say, hey, I think this person needs to come up to your hospital, and I get some sort of snarky response like, you want to transfer this person to Spokane?
Yeah, that's not very helpful. So part of the service is supposed to be, we have these pretty detailed maps where we can click on a site and it tells us what level of service they provide. Do they keep their IV TPA patients, where they send their IV TPA patients in their interventional, and the stroke provider is supposed to know that. So no excuse for, number one, snarky response, and number two, not trying to help facilitate it. What you will notice in patients who aren't from our hubs is sometimes it takes a little longer for them to connect the dots. But I liked feedback, and Archit Bhatt, who's one of our St. Vincent stroke providers, but also the medical director at the system level, which has been rebranded Enterprise level, likes to hear feedback about those kind of calls, because we have to check our provider behaviors. Hopefully that's not. I'm sorry, go ahead.
Oh, letting Sarah or Carrie know, we can follow up with that through Dr. Bott or Dr. Longkoff.
I think that's the beauty, is always just making sure that you give us feedback, even if it's not just from a snarky response, but if you have perceived delays, let us know. Transfer centers, it's a big process that we're working on, trying to streamline processes in emergency situations like stroke transfer. So we always welcome the feedback to try to make our system better.
Yeah, and I tell the ED directors and ED docs, here's my cell phone number. I know I've had conversations with a number of you, Dr. Grupis and others, about specific cases or processes. So I'm happy to share that. You can text me, and I'm happy to talk to you. It's nothing like, in the moment sort of issue, or yesterday this happened, to work these things through. All right. I'm sorry, go ahead.
Yeah, this is Scott Grupis. Two things I put in the chat, but we do appreciate the neuro consults. I have people that are outside of TPA window, but then I don't have a neurologist to talk to. And in my experience, that's been helpful to get somebody on the phone and tell me, even if it's Plavix and aspirin or whatever the deal is. So that's been helpful. And then Aaron had a comment about who is supposed to find a bed, who is supposed to find the patient a bed at the stroke center after we give TPA, and I would agree with that. I felt like when we first laid out this whole process, and and Sarah, Vincent, you could speak to Good Sam as well, because I'm not sure. Do I talk to the hospitalist? Who do I talk to? And do you guys, in your case, the stroke provider, do they accept the patient, or is it somebody else accepting the patient?
Yeah, so it has several steps to it, and that's another piece of feedback is, are you guys getting good service in terms of getting the patients out of your EDs and to where they're supposed to be going through our transfer center? It would take a little bit of time to describe all the different steps there, but if you have a telestroke provider and they're not the one who's on call in Portland, they're supposed to call the stroke provider who is on call for that transfer. They're also supposed to activate the thrombectomy case provider through our transfer center. And then who you end up having a conversation with, whether it's the stroke provider or who is the placeholder, we should be accepting the patients in transfer as the accepting physician. Sometimes intensivists want to talk to you. Sometimes hospitalists want to talk to you about non-TPA cases. You may get asked for a variety of different permutations of that. But what we do need is feedback on when there are problems, when it seems like it's taking too long. And I have asked our transfer center to let us put a time limit on that. If it's taking too long, an instruction should come to your ED, particularly with thrombectomy cases, that you need to look at another healthcare system. There will be times where we can't take the patient, but those should be, count them on 2 fingers on one hand each year. So hopefully that's clear in answer to your specific questions about who accepts the patient and how they get transferred. But you will be talking to different docs depending on how what type of case it is and which facility the patient's going to. And I guess the simplest way of putting those words, you guys should not be trying to figure that out. It says, I have had a stroke doc. Yeah, I'm reading Aaron's note. I've had a stroke doc tell me that finding a bed is an expectation of us as an ED doc. Other times they've told me it's their responsibility. So you call our transfer center or you're connected to our transfer center and it's their responsibility to find a bed. But if it's for the endovascular stroke treatment, we're going to be taking the lead on that. But if you have a routine neurology patient you want to transfer to one of our hospitals, you have to call our transfer center. So it sort of depends on the case. Hopefully that answers that question. I know we're running over time here. Almost done. Someone was speaking, asking a question.
Yeah, this is Raj Bayman again. Quick question. The couple times a year you said when you might not be able to take endovascular cases, we might have to find a bed elsewhere, or thrombectomy cases, I should say. What other hospital systems can do thrombectomy? I would assume OHSU and Legacy. Is there anyone else in the state?
So OHSU does them. Legacy, Emmanuel does them. They do them in Bend. They do them in Eugene at Sacred Heart, and they do them in Medford. Prov Medford has a part-time schedule, but Rogue has a full-time schedule.
Okay,
and
good. Thank you.
I will say that this COVID has complicated things, especially recently. So I know this weekend there was a case that was turned down by Corvallis and Eugene before they had no ability to transfer in. So we are working hard to help you find a place for your patients. It is an ongoing struggle, especially right now.
Yeah, and that would be an example. If you had a case where it was tough, please let me know. I give if the feedback works the other way. I got a call from a surgeon at Prov Newburgh this past weekend who wanted an acute stroke consult, but they didn't even call the telestroke provider. So we get calls from the wrong places sometimes, and the only way to correct it is to hear feedback about when things didn't work well.
And I see a hand from Stephanie Duckett.
Unmute.
Yes. Yep. I would say yes. I have to live on mute. Quick question though, when we're talking about thrombectomy candidates, are we talking about any acute stroke symptoms in under 24 hours is considered a thrombectomy candidate, or are there exceptions to that rule?
So that's where the CTA comes in. The CTA will tell us whether there's a large vessel occlusion. The patients who typically go are distal internal carotid, middle cerebral artery, proximal branches, basilar arteries sometimes will go. But when we look at the CTA, we can tell whether it's an accessible clot. And we can tell if we can't, if we're not sure, we always review it with our interventionalist saying, do you think you can get that? And so we have that conversation on our end before the transfer, unless it's a slam dunk. And then we just get it rolling and call the IR person afterwards.
So we can expect guidance from you as to whether or not we should be advocating for thrombectomy for the patients in our EDs.
Yeah, so the way to keep it simple is disabling stroke deficits under 24 hours, CT, CTA, conversation with the stroke provider. All right, very good questions. Thank you all for that. This will be the last slide, I think. So these were things I wanted to talk about. Posterior circulation strokes, that's an hour talk. I'm not going to be able to talk about it in this time frame, which was mostly logistics. But if this was useful to you, happy to do a session where we just do a quick data review and one topic kind of thing, or any cases you want to review. Posterior circulation, vertigo, really tough one. What's really interesting in Eugene, they did a program where they had physical therapists on call to the ED who had specialty training in vestibular testing. And sometimes the nystagmus is there, sometimes it's not. But if it's classic for a peripheral vestibular, they were sending those patients home at a rate of about 20 to 30% without any brain imaging, which is really reassuring. To me, the single most useful thing for altered mental status or vertigo is, do they have a field cut? Because that's posterior circulation. Do they see the fingers moving? But again, a separate session. Stroke diagnosis in challenging patients, we could kind of lump that with the first one as a didactic. And I would be happy if there are a lot of naysayers in your community to take a swing at the thrombolytic controversy. I did bring Jerry Hoffman up to Portland and have him do a point counterpoint, which is available online, with Greg Albers, who's the stroke program director. I kind of think of myself as someone who's on both sides of the line. You can hear my lack of enthusiasm for the 3 to 4.5 hour time window. I think there are real limits on thrombolytics, but in selected patients, I think the data says that it does have benefit. But happy to give a talk on that, and happy to review literature. And I keep seeing articles saying, the emperor has no clothes. So from the ED side of things, so happy to talk about that. I'm going to stop there. Thank you for your time. I hope it was useful to you.
Ted,
and I'll take any last questions.
Dr. Braun has his hand up.
Okay, doke.
Ted, quick question. We recently have had a little bit of this is Mark Braun from Albany. We have had a little bit of a problem where what we normally do is, when we're giving TPA, we start preparing platelets for those patients in case there is issues where they have hemorrhage and we need to do some reversal. And because of some platelet shortages, we're not getting the platelets in Albany, and we would have to have them shipped over from Good Sam. So there'd be a kind of a delay there. So we had talked in our most recent stroke task force meeting about what sort of options we might have to institute into our protocol to have on hand that maybe you could recommend, or what there might be out there as far as options to have available instead of platelets in those particular cases, and what, if you have any advice for us, that'd be great.
Yeah. So what I'll do, and I'll take this offline, I'll share it with the group. I'll share our protocol with you. If it does not specifically address your question, I will ask a hematologist what the option would be, because I understand your apprehensiveness in not having something on hand.
Excellent. Thank you.
Please remind me if you haven't got an email from us within the week.
10-4.
Any other questions?
Ted, it's Melissa. Just two things. Just a reminder that Dr. Lonekoff wants you all to know that he's quite open. He can share, or I'll share his email in the chat window for any questions that you want to reach out for and have something that specifically physician related that you would like to have answered. Please also continue to send us feedback for transfer issues through Sarah and Carrie. We meet with them. We used to meet weekly, but now it might be monthly, but still that channel of communication is always open, that we just want to make sure that we're always improving our service. And then just the last thing about transfers is if you're ever in the middle of a transfer and don't know what's going on, your call is to the Organ Transfer Center. Just be sure that when you reach out to them that you say that it's an ongoing, it's not a new activation, you're trying to figure out what's going on, and the transfer center will know. They're either paging the interventional radiologist or they're paging the stroke triage doctor. And the transfer center also knows who has beds where, because when they transfer into Portland, it can come to one of 4 sites. So the transfer center is your place to go and I know sometimes 5 minutes can seem like an eternity when you're trying to get somebody out the door, but yeah, the transfer center is the place to get information about what's going on. Any other questions before we wrap it up?
Great. I really appreciate all your time and this really excellent turnout. I hope this was useful to you. Happy to do it again in whatever format, didactic, case review, data review that you like. That would be helpful to you. But really appreciate the opportunity and working together. I think we do a pretty good job taking care of acute stroke patients, and hopefully we can extend to the non-acute over time.